Hello, my name is Rachel C., and today I will be presenting case connections for Unit 4 for the University of New England online medical biochemistry course. I have decided to discuss both Case 2 and Case 3. I will start with Case 2. This case presents two infants who are both currently being evaluated as they are suspected to have phenylketonuria, which is also known as PKU. For the rest of the case, I will start to refer to the disorder as PKU. The first patient, also known as patient A, is a 4-day-old infant that is being followed in your clinic. Her birth weight was 5.9 pounds, and the pregnancy and birth were normal. Results from newborn screening demonstrated a phenylalanine level of 6.6 mg per decimeter. The normal range is 1.2 mg per decimeter. A presumptive diagnosis of PKU was made, and additional samples were obtained for further analysis. The parents deny a family history of PKU. As consequence of this presentation, which amino acid may become essential? There are two types of amino acids, essential and non-essential. Essential amino acids are those that can be obtained from the diet, and they are from foods that we eat. The body does not produce them. Whereas non-essential amino acids are produced by the body. They do not need to be ingested. In the diet as they can be formed in the body. Going back to the question on which amino acids may become essential in the case of PKU. In this case, there is an issue in the metabolism of phenylalanine, which is why there are elevated levels of it in this baby. In a normal case, phenylalanine, which is an essential amino acid, is converted into tyrosine, which is normally a non-essential amino acid, by an enzyme called phenylalanine hydroxylase, with the assistance of a cofactor called BH4. But because there is an issue with conversion, tyrosine is not generated by the body, thus resulting in tyrosine being an essential amino acid as the body is not able to generate it. Therefore, it is only able to be ingested from the diet. Dietary restriction was initiated at 14 days of age for patient A, with a good response of plasma phenylalanine levels that dropped to within normal range. What are the potential causes of the presentation of phenylketonuria? PKU can be caused by two issues, one of it being if there is a deficiency in the enzyme that converts phenylalanine to tyrosine, which is phenylalanine hydroxylase. There can be a buildup of phenylalanine that is shown in patient A earlier on. It could also be due to the deficiency in its cofactor BH4. Therefore, if there was a deficiency in BH4, this reaction would not be able to take place normally, which causes PKU. Next, we have patient B, who is also being evaluated for suspected PKU. BH4 loading tests are performed on both patients and the results are presented below. The purpose of this test is to determine the effect of this enzyme, BH4, on the metabolism of phenylalanine. Blood is drawn on both babies before the loading test, 4 hours after the test, and 8 hours after that. There is a graph shown in the case study, but I'm going to give a brief explanation of the graph. In the graph, it is shown that patient A, after the BH4 loading test, given the 4 hours and 8 hours, phenylalanine levels do not change very much. It had in fact increased just a tad bit, but nothing significant. whereas patient B levels has decreased at 4 hours and even more at 8 hours. Both babies are responding differently to the BH4 loading test. The prompt asks, how would you summarize the results of this test for patient A and B? For patient A's, level of phenylalanine increased over time, which makes me think that the baby's PKU is most likely not due to the deficiency of cofactor BH4, but due to the deficiency of the enzyme that converts phenylalanine to tyrosine. Whereas patient B seems to be responding very well to the test, which allows me to think that the reason that the phenylalanine levels are decreasing is that patient B is most likely to have a deficiency in the cofactor BH4. Next, I will present case 3. A 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot, and there was no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urinalysis is performed. The results from this individual are listed below. As we can see, the patient has high levels of plasma urate and low levels of urinary uric acid. What is the best explanation for the presentation of gout in this individual? And please explain why the other choices are not consistent with the data, or what additional information you may need to decide the root cause. Number 1, overproduction of purines. Number 2, decreased salvage of purines. And number 3, decreased urinary excretion of uric acid. Starting out with number 1, overproduction of purines would most likely lead to gout and increased uric acid levels. One of the disorders caused by this is von Guericke's disease. However, this disease includes many prominent symptoms which are not included in this scenario. For instance, low blood sugar levels and stunted growth. In order to test for this disease, blood sugar tests, genetic tests, and lactic acid tests would need to be carried out to identify this disease. This is most likely the answer, as gout is an inflammatory crystalline arthritis. When uric acid levels are elevated, it leads to depositing monosodium urate crystals in the joints. This results in the swelling of the joints. The body itself produces uric acid normally, and the rest comes from our diets in the forms of purines. The second option, decreased salvage of purines. This is likely not to be the answer, as the patient has increased levels of plasma urate in his blood. This means that there is no decrease in purine salvation. The third option, decrease in urinary excretion of uric acid. This option would be wrong, although the patient has less uric acid in his urine compared to normal results. It is most likely that the patient could be suffering from kidney problems, as the result of uric acid levels are low. Other likely information that are not present could be the medicine taken by the patient, their physical health, and their medical history. After further discussion with the patient, he tells you that he recently switched from diet soda to regular soda because he read that the fake sugar diet was bad for him. He tells you he drinks between 4 and 5 liters of soda a day. What is the potential impact of this dietary modification on the presentation of gout? As the patient had mentioned, he consumes 5 liters of soda daily. This is bad as soda contains a high amount of fructose, which contributes towards gout. Thus the patient should be given more education on the consequences of fructose and the importance of a balanced diet. Thank you.